to leave the session midway through your talk. I'm really sorry, but I've got to catch my flight, so my apology in advance.
Yeah, okay. Thank you very much for the introduction and for noticing me. Otherwise, I would be sort of thinking I bored you. Okay, first of all, I'd like to really thank the organizers and Claudia for organizing this really great meeting and invited me to give that talk. The task I was giving is talking about preoperative optimization and postoperative outcome from alpha to omega, and I slightly changed. These are my disclosures, so I work with some companies that are engaged in that field. I slightly changed the agenda, and we'll start with omega, and we'll talk a little bit about the risk of surgery, and then in between, what might be the role of optimization, and then alpha, how we could potentially implement that into our daily care. So the risk of postoperative complications. The good thing if you work as an anesthesiologist and intensivist caring for peri-op patients is it's really a big business. This is pretty recent data trying to estimate the volume of global surgery. And as we can see, it's really a lot of patients we take care in our ORs and in our ICUs worldwide with more than 300 million surgical procedures performed worldwide. And the interesting fact, especially if we look at smaller countries, the true mortality rate is really unknown. But we can estimate from previous studies that somewhere around 3 to 12 million deaths each year after surgical procedures. And something we learned also after the election in the United States, that if something really bothers the general population, it will be in The Simpsons. And as we can see from that screenshot, obviously people are caring what we are doing in the hospitals. As it says here, come for surgery, stay for the complications. So this is something from the real world, and we heard that before, that this is really a nightmare if you go to surgery to get a new hip and end up with some severe complications and your functional capacity is really lower than it was before you came for surgery. And this is also, happening. And there's data out there that shows that the risk for complications after surgery is really high. This is data from the Gaffrey group, and we can see that the incidence of post-surgical complications is about a quarter of the patients and severe complications about 16 to 18%. Obviously, this depends on the surgical procedure and the patient status. And here is a study from the same group where they summarized the risk of developing complications after surgery grouped according to the surgical procedure. And we can see there are some surgical procedures where it really makes sense to think about optimization strategies. For example, if we see that in esophagectomy patients, about a half of the patient will develop postoperative complications. If we look now at some recent data, looking at the theme of complications and mortality and the outcome measure failure to rescue after surgery, we have now data from the ISO study published recently in the British Journal of Anesthesia, and they included almost 50,000 patients from almost 500 hospitals from 27 nations worldwide, and also from nations from the second and third world countries. It's a pretty nice data set looking at global surgical volumes. And again, we can see a substantial number of patients developed complications after surgery. In that study, it was 16%. Only 0.5% died after surgery in that study. You might recall in the user study it was 4%. This is highly discussed, what might be the difference. And there is a failure to rescue rate of almost 3%. That means patients developed complications, and we were not able to recognize that in a timely manner, and those patients died. Obviously, and this is data from the user study, there are some differences between countries. We all know that it wasn't a very wise decision to basically put up the names of the country, because obviously it was a random sample of hospitals from those countries. But the interesting fact is that some hospitals in those countries, in those hospitals grouped according to countries, did better than other hospitals. So the point is, we can certainly do something about it. And the task and the question I was given is goal-directed hemodynamic optimization a piece in the puzzle to prevent postoperative complications? And obviously, we know volume management during surgery and potentially in the ICU has a very important point in the fact whether patients will develop complications after surgery or not. And we know from pretty old data by now that if we are too restrictive with our volume therapy, that's not good for the patients. And if we are too liberal, that also increases the risk of complications after surgery. And a pretty recent study that again showed that in patients undergoing colonic surgery showed that U-shaped curve again. They basically grouped their patients according to a low volume proportion, the reference volume, and a high volume. And you can see this U-shaped curve with the length of stay and the total spending of the hospital for those patients. So obviously, it makes sense to target the right spot of volume therapy in those patients. The problem is, and that was very nicely stated by Professor Jarisch more than 100 years ago in der Deutschen Medizinischen Wochenschrift, that it's fatal for our understanding of circulation that we can measure blood pressure so easily and flow so sort of complicated, and that leads to the fact that caring for patients, we tend to look at blood pressure and not really flow-based parameters. Well, that was a long time ago. However, this is a newer review looking at volume trials in ICU patients, and we can see that when we think patients need volume, we are wrong in about 50% of the time, as in those studies, only 56% of the patients responded to a volume trial when doctors thought that patient needs volume, but in fact, they had enough volume and had other problems for their low blood pressure. And this was sort of tackled by this nice interview of anesthesiologists and intensive care physicians from Europe and America, done by Andreas Höft, Asriel Perel, and Maxime Canesson. And you might know that data, that still nowadays we rarely use cardiac output monitoring in high-risk surgical patients in the OR, and after surgery also rarely in the ICU. In that study, about a third of the patients, according to the interview of those doctors who took part in that study. And in fact, I think the real incidence is lower. This is a quite new study where they basically did the same thing. And you can again see that this is the respondent where they stated more than 70% of the time they tried to keep the patients in a safe limit according to pressure-based parameters, and this is cardiac output. So you see cardiac output still plays only a minor role. It's a little bit more in that Japanese study compared to the Canesson study, but still we don't use cardiac output monitoring on a regular basis. And this is from the users study monitoring data. And again, we see volume therapy is still in a lot of cases based on pressure-based parameters here, central venous pressure, emergency cases. And this is cardiac output data. This is arterial pressure waveform, which is increasingly used. Doppler, only rarely used, and the PA catheter only in a minority of those patients. And I learned yesterday you have to shake it, okay, yeah. And this is ICU data from a ICM endorsed study, the ICU CardioMan study, who looked at daily practice in German-speaking countries, Austria, Switzerland, and Germany. And basically the question here was, what kind of monitoring was applied to your patient when the point prevalence study took place? And we can see cardiac output monitoring in the ICU less than 20%, pressure-based, 60%, volumetric, dynamic, and microcirculation only in a small subset of patients. So most of our daily practice, we do volume therapy and inotropic therapy based on pressure-based parameters. One final comment about monitoring options. We all know that a lot of our hospitals have echocardiography machines available, and that was quite fascinating in the ICUs who took part in that study. More than 90% had echocardiography available in their ICU, but we see only less than 2% had actually a study done within the last 24 hours. So we see that is also not used very often to basically guide our hemodynamic management in the ICU or perioperatively. So the question is, how can we address the spot of normovolemia in our patients in the OR and in the ICU to do some sort of individualized hemodynamic management and monitoring? And the question lies, well, the answer to the question lies somewhat in physiology, because if you want to know whether your patient is volume deficient and you want to increase it, one option is to measure stroke volume and do an individualized approach by giving volume boluses to your patients and repeat that until you see no significant increase in stroke volume. The other option, use dynamic parameters like stroke volume variation or pulse pressure variation, where you see that swing in the A line, and then you can optimize that according to those parameters. Or you can use echo, where you see that this patient has obviously some sort of volume deficit, and then you can optimize it with the dynamic parameters. Now you see the swing in the A line has disappeared, or you can try to use echo to do basically the same thing. If we look at aggregated data, the best thing to address the problem of volume responsiveness is use pulse pressure variation followed by stroke volume variation, but we know we can't use that in all our patients. Spontaneous breathing patients would be an exclusion criteria, and it's probably not the best idea to use the central venous pressure. So stroke volume optimization or functional hemodynamic parameters are probably the best way to address the problem of the right amount of volume that should be given to our patients. And now I come to some protocols, how you could use that in daily practice. And we can have a short look on some studies, well, basically one study that looked at outcome relevance of those approaches. Basically, all approaches to hemodynamic optimization follow those steps. We have to think about the adequate amount of volume for our patient. Then we have to look at the cardiac function and then the function of the vasculature. And if we look at the ESA patient safety site on the internet, there are some protocols being published, and basically the protocols depend on stroke volume optimization with fluid. There are some studies using oxygen delivery optimization with fluids and inotropes, and dynamic parameters optimization with fluids, and also some combination. And as I said before, basically the idea is first start with the optimization of the fluid status and the stroke volume with parameters you like to choose, then optimize inotropic support, and here the evidence is quite low. What might be the right cardiac index for the individual patient, and then after that's done, optimize perfusion pressure to the right mean arterial pressure, and having done that for the individual patient, we have to think about the right heart function. Some literature, and basically I didn't want to bore you with one of the major problems in the field, that there are many randomized but open-labeled single-center study with small numbers of patients. So I just took the optimized trial run by Rupert Pearce in the UK, which is a bigger multi-center trial. And as we can see from the p-value, this trial was negative. The p-value was 0.09. We can still see that there is some separation of the usual care group compared to the intervention group regarding mortality in those patients at 180 days, but that trial was negative. There was much discussion about this result. Basically, that trial would have been positive if all centers would have excluded their first 20 patients, because there seems to be some learning curve. And the authors published within that paper a meta-analysis of all those single-center trials with small numbers of patients. You can see here the numbers of patients, where there is some signal that this intervention might have some sort of benefit to our patients in preventing postoperative complications. You see the relative risk, if you take in that meta-analysis all studies together, is 0.77. So real-life implementation in surgical patients. And now we know basically the evidence for that intervention, and there are some studies. I just took that one. This is a very nice study, and it's sort of typical for things, how things are run in the UK. There's a group of people from the emergency laboratory network, and they did a study before that where they saw that they have a quite high mortality in patients undergoing emergency laparotomy. And then they came together and sort of said that we have to do something about that. And they came up with those bundle of measures. Basically, it established an early warning score, identifying the need for emergency laparotomy in the individual patients. Then they sort of said that we have to give pre-op antibiotics timely. Then after the decision that that patient has to undergo laparotomy, the real laparotomy has to be done within 6 hours, which is not always the case, at least in my hospital. Then they said, okay, we will use this intraoperative goal-directed fluid therapy. Then all patients went to post-op ICU, which is also an intervention with very debatable benefit for the patients according to recent data. And then they said, okay, the consultant should do the anesthesia, and the consultant should do the surgery also at nighttime. And here is the result. You can see some of those interventions in some centers were implemented. If we look at goal-directed fluid therapy, which is the task I was giving to talk about today, you see that in most centers there was a significant increase in that intervention in the after implementation phase. And you can see that this bundled care had a substantial effect on outcome. You can see that the mortality from those 4 centers decreased from almost 16% in those patients to a little bit below 10%. So obviously, if we talk about doing something good for our patients, it's not one factor that will change the world. And the risk for our patients is obviously coming from the surgical procedure and from the patient, but also from our perioperative treatment strategy. And if we look at how we are sort of guided to implement strategies to improve outcome, we should try to identify patients at risk and treat clinical problems. And identifying patients at risk obviously takes place preoperatively, where we have to identify patients who would benefit from certain interventions, and that's beyond the fact that we should do perioperative optimization of the hemodynamic system. It's also perioperative optimization of the pulmonary function, anemia, and whatever. And then intraoperative, there is a part where we should think about implementing perioperative goal-directed treatment. And then later, postoperatively, obviously, we have also to use bundles and guidelines to treat our patients optimally. And this is for the intraoperative, the suggestion from the enhanced recovery group that we should try to target our therapy according to patient-specific risk factors and procedural risk factors. And in the high-risk group and in the intermediate risk group, there might be a benefit for goal-directed fluid management, and in the low-risk group, it's probably not necessary. So my conclusion would be the risk of surgery is substantial. We have a lot of patients that develops all sorts of complications postoperatively, and it depends not only on the patient and the surgical factors, but also on our perioperative treatment strategy. And goal-directed hemodynamic optimization is only a piece in the puzzle, but in that piece, one size certainly does not fit all. We have to use the right parameters to basically target the right fluid management for our patients. And implementation is obviously possible, but patient identification and the adequate monitoring and treatment strategy for the individual patient will remain a challenge in the future. Thank you very much.
Thank you very much, Michael, for this inspiring talk. I think what's very important is how we measure that what we think is good for our patients is really good for our patients. That means you mentioned postoperative complications. Did you follow up on that, what we are doing? Is perfusion relevant for post-intensive care syndrome or post-surgical syndromes?
That's a very good question, and basically the literature is really sparse in that. The biggest problem in the goal-directed management literature is that people tend to look for hospital stay, but not for functional outcome after months. So the optimized study was planned very wisely with a follow-up of 180 days, but and that was the reason why I decided against showing you like 10 positive or negative studies with a follow-up of 7 days, because basically we should do better for our post-op patients because they expect more for us than surviving for like a week longer. They expect for us, especially if they go for elective surgery, to do better for the next years. Well, we will hear about that maybe afterwards. But I could really imagine that if I would now say, okay, we can decrease hospital stay by 2 days, but we won't make a difference in functional outcome after 1 year, then the patient would probably say, I really hope for more.
Any more questions from the audience? So thank you very much, Michael.
Thank you.